Hello guys. Sorry. Hey guys, hope I'm audible and visible. Hello Bengal Medico. Hello, good evening, Ipshita. Hope I'm audible and visible. Great. So we are going to have a brief discussion on the chapter Neoplasia. So Neoplasia is something when we started reading Neoplasia would have looked like a very, very big chapter, right? But when it comes to the FAGAN, Neoplasia is actually not a very big chapter. There are very, very, very few places where exam for a second year exam point of view, an exam question can come, right? Most of them are understanding concepts which we apply repeatedly in systemic pathology and hematology, so that our concepts would have been much more stronger. If you generally look at the term in with respect to a long answer question or a short answer question, there's a probability that they might ask you in total about the molecular hallmarks of cancer, which is a very, very, very big topic. I'm sure you must have recognized that as well, right? So if a topic like that big comes, please don't be stumped. Please don't try to write everything. Write important salient points in each of them. That's a possibility it can come, right? Paraneoplastic syndrome, tumor markers, metastasis, these can come as a short note. Your oncogenesis, especially the microbial carcinogenesis, can come as a short note, right? Sometimes microbial carcinogenesis can also come as a long note where you have to just elaborate whatever we already know, right? So these are few places I will be touching about it today, and also we'll quickly go through about the molecular hallmarks. If it comes in a long answer, what to write, and in between also you'll say if it comes in a short answer, like one particular gene, P53 gene, what all to write, we'll definitely try to extrapolate it so that we are comfortable whether it comes as a long answer or a short answer, we'll be able to write it, right? Good evening, Shushmita. Good evening, Vinay, Jansi, Afan, and Ipshita. Fine. So with that note, let's start. So the first question I'm going to discuss about is metastasis. I'm discussing only the metastasis part. I'm not taking about the steps of metastasis. We'll look at the steps of metastasis later along with the molecular hallmarks, right? So metastasis, the format for every general pathology question, I cannot create a template. It has to be individualized based on the question. There's a definition. Metastasis is defined as a spread of tumor to the sites that are physically discontinuous. This word is very, very important. From the primary tumor, it could be the lymph node, it could be just adjacent tissue, it could be from the lung to the pleura, your heart to the pericardium, everything, right? Okay. Good evening, Muthu and Srimati. Fine. So that's my definition. There are three primary routes of metastasis, which are lymphatic, hematogenous, and seeding of body cavities, right? Can anyone tell me one which is most common amongst these? Lymphatic, hematogenous, seeding of body cavities, right? By default, lymphatic route is the most common route of metastasis. Which tumors prefer lymphatics? Carcinomas or sarcomas? Undoubtedly, carcinomas, right? See, when we started reading Neoplasia a year back, right, it would have been very difficult for us to remember how do I know lymphatic will go to carcinoma and hematogenous will be sarcoma, right? But now I'm sure everyone must have examined breast cancer patients. Breast cancer, the first thing you look for is axillary lymph node. Lymphatics, carcinoma will go to lymphatics by default, right? That's a primary route, right? So whenever you write about lymphatic spread, I want you to add a word about sentinel node biopsy and the sentinel node, right? Because sentinel node is something which I'd expect I'll be very happy if it's there in the exam paper, right? Sentinel lymph node is the first lymph node which drains the cancer, fine? Sure, right? Which is going to drain the cancer. Okay, the importance of sentinel lymph node biopsies. If this is involved, obviously every other axillary node will be involved in the respect of breast. If it's not involved, there's no involvement at all, right? So the use of sentinel lymph node biopsy is to modify the management of the patient. If it's a long answer, please write what do you mean by modification of the management. As simple as that. A patient with breast cancer has a lymph node involvement, you do a modified radical mastectomy along with a lymph node dissection. Breast cancer without sentinel lymph node involvement, you just do a modified radical mastectomy, right? You can, fine. No, Rishank, that's what I said in the start. Neoplasia looks big, but whatever in neoplasia, what we read in the initial general pathology are now all applied concepts. There are very few places where we'll be discussing exam point of view questions. Neoplasia is actually much more smaller than the other things, right? So then let's come to hematogenous. Hematogenous route The common organs which will get the hematogenous metastasis, lungs and liver. Any systemic organs will go via hematogenous metastasis only, right? Be it brain, bone marrow, everything, right? Predominantly lungs and liver. And it's most commonly, it's preferred by sarcomas. Okay? Because sarc is fleshy, obviously it can go to the hematogenous route. There are few exceptions. Exceptions is important. Few sarcomas which will have a lymphatic metastasis. Okay? So lymphatic mets will be there in few sarcoma. SCARE. Anyone? S stands for synovial sarcoma, clear cell sarcoma. A stands for angiosarcoma, rhabdomyosarcoma, and E for your epithelioid, epithelium-like or epithelioid sarcomas. Fine. All these can prefer and go to your lymphatic routes. These are sarcomas which prefer lymphatic route. Again, that will make sense for us. Okay, I know a little bit about hematogenous route and also an exception for it, right? Then seeding of body cavities. Seeding of body cavities, classical example, you can write any body cavity. Like I said at the start, lung to the pleural space, heart to the pericardial space, everything is seeding of body cavity only, right? But most important for me is the peritoneal cavity. And intra-abdominal malignancy or intra-abdominal tumors seeding the peritoneal space, right? Why I'm mentioning peritoneal space here is I'm sure you will know a classical example for seeding of body cavities. What is this example? A place where you have lots and lots of mucin deposits in the entire peritoneum. We have perfect. And classical example is in pseudomyxoma peritonei. This has to be there. We expect this. Pseudomyxoma peritonei is nothing but, like Ipsita said, it is a mucin secreting tumor of or mucin secreting adenocarcinoma of your, can be an ovary, can be an appendix, can be a colon, where the entire thing ruptures and goes into the entire peritoneal space, where it will have deposits of mucin secreting tumors and also freely floating mucin, right? As a classical example, pseudomyxoma peritonei, terminal stage, can't do anything, right? Few rare types of metastasis also needs mention, right? One is drop metastasis. Where do we see drop metastasis? See, now actually it is simple. I need not memorize it because we have read about medulloblastoma. We know about medulloblastoma. It's a tumor in the cerebellum or the posterior fossa. So it can automatically drop into the spinal column, right? So from cerebellum, any cerebellar tumors can drop into along the spinal column. I call it a drop metastasis. Intravenous growth. We did read them in the RCC and the HCC, where it can grow into the veins. This is not an intravascular growth. Here, the tumor grows, does not spread, grows into veins, right? Classical example is RCC and HCC. It can go into the renal vein and reach the IVC, and even sometimes can go up to the heart, right? There's one more tumor. I would not consider intravenous growth for prostate. I think that you were saying about the Bateson's plexus and reaching the bone. That is a hematogenous spread. It is not an intravenous growth, right? Okay. So here it's growing into the vein. It is not spreading by the vein. It is growing into the vein, right? One more thing. I'm sure you know that answer as well. What do you think is the classical example when ovary is involved? It is Krukenberg's tumor. Krukenberg's tumor is ovarian secondaries. It's a type of lymphatic spread only, but we call it an retrograde lymphatic spread. It's not the routine one. It's a retrograde lymphatic spread. Okay. And one of the tumors which can result in Krukenberg is diffuse gastric cancer. And one more thing is lobular carcinoma of breast. See, now we actually, every question in general pathology, you can write a lot. Because what is common between diffuse gastric cancer and lobular carcinoma of breast? CDH1 mutation or E-cadherin loss. So now you can actually explain why it is going behind or the retrograde direction. Because I don't have E-cadherin, I don't go as a clump. I am just spread. So one can go forward, one can go backward, right? So you can actually explain all the things you know. General pathology is actually an accumulation of all the systemic pathology. When we studied general path in the first, I would have given examples. Now you can relate the examples. General path is much easier, and I'm sure most of you will start revision with general path much comfortable. But later on, when it comes to systemic path, we will struggle. That's why we went the reverse from the systemic path to general path, right? So that's about metastasis. Mets can come in an exam, and Mets, if it's, we know all the types. If I have to write about the gross of metastasis, please remember that whenever I see multiple well-defined lesion in the periphery of an organ, periphery of any organ, I would always think of metastasis, fine? Retrograde in sense it's backwards. Antigrade is forward, retrograde is backwards. That's all I'm saying, fine? Okay. You can draw a specimen of liver if required. In Robbins also there's a specimen of liver. You can say there's multiple rounded tumors here close to the capsule. I'll think of a metastatic deposit, fine? Okay, so we know about metastasis. Mets, there's a possibility definitely can come in a 5 mark. If not, definitely you'll have a specimen of Mets in your liver, which can come in a gross. Okay, let's go to molecular signals. How backwards? See, how backwards? I have explained this before, but I'll still explain here. A tumor from the stomach goes to the celiac plexus. The antegrade route of any lymphatic system is to go to your azygos, hemiazygos to the thoracic duct. That is normal. But here, the tumor from the stomach or from the breast, rather than going to the azygos, hemiazygos, it's going to the reverse route and coming back to the ovary. That is retrograde. That's backwards. Fine? Okay. Let's come back to this. I'm sure you remember the story of the kid who was 5-year-old and did all these things so for us to remember all the 8 hallmarks of cancer, right? So now we are going to read about oncogene, a general template that I can write for every oncogene. KRAS follows that, ABL follows that, JAK2 follows that, c-KIT follows that. Same way, a general template which can fit into any tumor suppressor gene, like your Knudsen's 2-hit hypothesis. It will fit into every tumor suppressor gene, right? So let's say I have a question on P53. I give information about P53. Okay, the guardian angel of genome, so and so place it is there. Everything I give. Then I write the Knudsen 2-hit hypothesis. Till I require the two mutations to happen. Then I add a word about the genetic or the inherited tumor, that's Lee-Fromney syndrome, and multiple organs where the tumor can happen, right? So it's again a template. I have one commonality which I can write for every oncogene, which I can also pitch for KRAS as well, right? So now let's go to cell sufficiency of growth factors, oncogenes. Simple terms, proto-oncogene is normal, oncogene is mutated part. Okay, right? So the common thing which will fit into every oncogene here is very, very simple. Every oncogene should have a gain of function mutation or amplification of the DNA. If it's a mutation, it has to have more function, that's all. Only when it's a gain of function, you'll have more division, right? So let's say there's a question on write about KRAS. So I'll say that, okay, KRAS normally does this function. When it's mutated, there's a gain of function. So the normal function of KRAS is to promote cell division. Mutation, more cell division results in a cancer, right? So whenever there's gain of function, the normal function of any proto-oncogene is to increase cell division or to help cell division. So when there's a gain of function mutation, automatically it's going to result in more cell division or more cell proliferation. That obviously results in a cancer. Okay. So if there's a general question on write about proto-oncogene, hi Devansh. Write about this, that's enough. And few important proto-oncogene which we have applied and learned in systemic pathology. I don't want you to remember the entire table of Robbins. It's almost impossible to remember the entire table of Robbins, right? So now EGFR receptor family is epidermal growth factor receptor family. There are two things in epidermal growth factor receptor family, ERB B1, ERB B2. Okay, ERB B1, the other name is EGFR, right? Devansh, receptor family is one. Under that, ERB B1 is your EGFR. ERB B2 is HER2/neu. I'm telling this HER2/neu because last year, I think in one of the INACD exam, they didn't ask antibodies to HER2/neu. They asked antibodies to ERB B2. People didn't know. So it's simple. I have already taught you what is HER2/neu. Everyone knows HER2/neu. The only way to ask a new question is change the name. That's all. So ERB B1 is EGFR. ERB B2 is HER2/neu, right? So ERB B1, where do you see? Or EGFR, where do you see? Like Devan said, one thing which I should not miss is lung adenocarcinoma in Asian population, in Indian population especially. It is not seen in case of a Caucasian population, right? Where do you see HER2/neu? HER2/neu is classically amplified, right? The classical thing is amplification of HER2/neu. Amplification of HER2/neu is classically seen in case of a breast cancer. Okay, simple. ALK stands for anaplastic lymphoma kinase. That's expansion. So obviously one tumor I know is anaplastic large cell lymphoma, ALCL. ALK is also seen in the same guy, lung adenocarcinoma. Okay. KRAS is the most common oncogene mutated in the world amongst the cancers. Three things. KRAS can be seen in almost every tumor. You read about adenocarcinoma sequence of quite a few tumors. KRAS will be one of the components, right? But don't forget colon, lung, pancreas. Because in these three, they are prognostic or they are diagnostic. In pancreatic adenocarcinomas, it's diagnostic. Without KRAS mutation, I'll not be able to diagnose it, right? Like Devan said, yes, I do see them in mucinous carcinoma of ovary also, but I don't want you to remember it because mucinous tumors or ovarian tumors are diagnosed with history, tumor marker CA125, MRI, biopsy. There's no role of genetics as on date for ovarian tumors. When it happens, we'll remember that, right? Till that, it's a fact. A fact which is not useful is generally not required for doctors, right? It's useful, it's required for me, right? This is your BCR-ABL that is seen in your chronic myeloid leukemia. We read about CML yesterday, right? JAK2, multiple tumors, but at least one thing, polycythemia vera, okay? But also seen in any not any myeloproliferative disorder. We'll write essential thrombocytopenia and myelofibrosis. It is definitely seen in these two cases as well, right? But don't forget polycythemia rubra vera or polycythemia vera where it is diagnostic. ET also is good, it's diagnostic only. Myelofibrosis also is diagnostic only, but don't forget your polycythemia vera. CKIT is seen in quite a few conditions, just classically seen. Seminoma, dysgerminoma, classically seen, and also seen in your systemic mastocytosis. Okay. So here also it's classically seen. CKIT is again like it's a simple tyrosine kinase only, not exactly like how your BCR-ABL works, but similar way it works here, fine. Okay, Rishan, HRAS and NRAS is ideally not needed for me because HRAS is seen in some follicular tumors of thyroid. I don't do more genetics there. NRAS is seen in neuroblastomas. Again, genetics is not much important there for me, right? So I'm just mentioning what are all required from me from a diagnostic point of view or a prognostic point of view. There is GNAC, there is GNAS in RAS also, right? Not required for me much, fine. Okay, so let's ignore it for now. But if you want to write more, I'm more than happy if you can write more. But don't miss this. So if you write this much, that's more than enough for me for a 5 mark, right? So let's take one gene a little bit in detail, which is RAS. So RAS here for me makes sense because RAS alone can come in a short note. Okay, when RAS comes in a short note, maybe you can add a word on HRAS and KRAS, put bladder tumors against the HRAS, neuroblastoma and few melanomas against the NRAS as well. I can add on to it, right? But not in a question of proto-oncogene, right? Let's take RAS. So for every proto-oncogene, if I have to explain it bigger, I have to start with normal. That's how it's very easy to write it, right? So RAS, you can write RAS as a proto-oncogene first. The proto-oncogene's function obviously is it helps in cell division. That's the function of RAS, right? So now this diagram what you're going to draw can fit in for almost any proto-oncogene, right? Draw a receptor. Okay. That's a growth factor receptor. I'm just writing GF receptor. On top of it, your growth factor comes and sits, right? Once the growth factor comes and binds to it, on binding, what happens? I have a molecule here that activates an inactive RAS to active RAS. On binding, this molecule is going to activate an inactive RAS to an active RAS. Okay. Once it becomes an active RAS goes into downstream pathway, two pathways, RAF pathway, Under RAF is where your BRAF comes into play, right? Below this, right? BRAF. I missed the BRAF gene also. BRAF is seen in melanomas, BRAF is seen in hairy cell leukemias, which also is an important proto-oncogene for me, right? Okay, we have BRAF here. This BRAF goes with one more pathway called as MAP kinase pathway, fine. The other pathway of active RAS is phosphoinositol triphosphate kinase pathway, okay. This goes to your phosphoinositol triphosphate kinase, AKT pathway, and these both are going to come to CMYC, which helps in cell division. This is normal template. This template can go for any proto-oncogene. If I'm talking about RAS, target this, stop it there, that's enough. Maybe don't write entire story down. Active RAS causes cell division, that's enough for me. But if they talk about BRAF, write a short note on BRAF. Same thing. From here, don't write MAP kinase, activated BRAF, cell division. Phosphoinositol triphosphate kinase activates that cell division. Normal, right? So now what happens is this, once you draw a diagram, also write here activation of RAS is only secondary to the growth factor receptor and the growth factor binding. That's important. And the second most important thing is it's inactivated immediately with one more protein called as GAP, right? It's a GTPase activating protein that inactivates it, right? So what happens? The GTP here immediately becomes GDP with the help of a protein called as GAP. This is a very, very important diagram. It has lots of components here. If I want to talk about neurofibromatosis, GAP is a problem there. This guy, phosphoinositol triphosphate kinase, is inhibited by PTEN. If I want to talk about an endometrial tumor, PTEN activation in general, PTEN is a tumor suppressor gene because it inhibits. GAP is a tumor suppressor gene because it inhibits, right? I can add to that, that's all. It's as simple as that, right? Okay. So now, once there is a gain of function mutation of RAS, this will make RAS active even in the absence of growth factor or the growth factor receptor. When this is active, automatically it's going to cause uncontrolled cell division, right? This image is there in Robbins. That's a very, very important image. Quite a few proto-oncogene, quite a few tumor suppressor gene, if it comes in an exam, you can draw the same image, stop it where it's required, eliminate the rest of it, right? You not write everything. If it's RAS, stop with this. Neurofibromatosis, concentrate on this. Melanoma, hairy cell, concentrate on this. PTEN hematomatous, Cowden, or your colon or your endometrial, concentrate on this. Burkitt's, concentrate on this. Here also one more thing comes is, along with this, it's not just that, cyclin D1 was also involved. Mantle cell lympho, concentrate on this. So this image can fit in for many tumors, right? So if there is a gain of function mutation, automatically itself imply that it is going to cause cancer. And since you asked, I do have KRAS, I do have HRAS, I do have NRAS. There are few more proteins which is there in the RAS pathway called as GNAC and GNAS. We'll ignore it for now. We'll at least learn about this, which we already know. Lung, colon, pancreas. Must to know. There are many other tumors as well, right? HRAS, bladder, and few variants of follicular CA. Few variants, not every other variant, few variants of follicular CA. NRAS, I can see in melanoma and few neurological tumors. These both are not mandatory for me for now for diagnosis, but if it's an exam, if it makes sense for us to write HRAS and NRAS, write about them also, fine? Okay, that's about RAS if it comes as a short note. When RAS and beta catenin does not have any association, beta catenin and APC has an association. Fine, APC beta catenin pathway, RAS does not come in the beta catenin pathway. Fine. If your question is why does RAS get activated in adenoma carcinoma sequence, that's additional mutation. Any mutation can happen in any cancer which is an unstable cell. Right? Okay. Let's go and have a quick look at the second hallmark, which is tumor suppressor gene. Tumor suppressor gene has the same template like one for proton gene. Template is simple. One, every tumor suppressor gene has to follow your Knutson's two-hit hypothesis. It's not only your retinoblastoma. Every tumor suppressor gene follows that. Fine. That's one. Obviously, every tumor suppressor gene will have loss of function mutation, or you can have deletion of the gene. Either function is not there or the entire gene is not there, right? Okay. So every tumor suppressor gene follows Knudsen two-hit hypothesis, but you must have never seen this term Knudsen two-hit hypothesis in systemic pathology. The only place I see is in general pathology. So how I describe Knudsen two-hit hypothesis in every systemic pathologies, have you guys noticed this word? Loss of heterozygosity. Have you guys noticed this word or LOH in colonic tumors, in endometrial tumors? Have you? MAP kinase is a transcription pathway which is downstream of BRAF and in between c-MYC. See, it's a kinase. Kinase is going to be protein activation. That's all. Fine. Loss of heterozygosity is what Knudsen two-hit hypothesis means. You can write slash and write loss of heterozygosity. So if it's in Viva, someone asks you what is loss of heterozygosity? Both being normal is homozygous, right? Let's say one is mutated. Can I call this heterozygous? Yes. If this is mutated, this heterozygous, then I'll have the loss of heterozygosity when the second also gets mutated. Loss of heterozygosity means the second normal allele gets mutated and it becomes homozygous. That's all. Okay. So loss of heterozygosity is nothing but two copy mutation. That's what loss of heterozygosity means. That's same like Knudsen two-hit hypothesis. That's all. And everything will be loss of function mutation only, deletion of the gene only, right? Okay. Now, tumor suppressor genes generally, if it's an congenital problem, congenital mutation, they cause cancer syndromes. There are few exceptions, but most of the cancer syndromes are made by tumor suppressor genes only by default. Fine. Okay. These are few things I want to write as a template. And then we look at few classical tumor suppressor genes and the cancers where it's seen. You will be able to fill it up for sure. I'm not going to tell, you are going to tell me, right? And if it's a short answer, write this table, write 3-4 points. We'll definitely go in detail about this guy, because these are potential short answers per se. Write about retinoblastoma, write about P53 can definitely come in exam, right? RB gene, tell me the tumors, top to bottom. Retinoblastoma and your osteosarcoma. Just the common ones. P53, there are multiple, right? You can have your sarcomas, can have your leukemias, can have the serous tumors, can have your breast cancers, and that's a most common gene mutated. CDH1, you know, just now we saw diffuse gastric cancer and lobular CA of breast. VHL, clear cell RCC and hemangioblastomas, cerebellar hemangioblastomas. There are multiple, we already know, right? APC, just colonic polyp. If you have time, write about attenuated FAP, Turcot, Gardner here because they are all variations, that's all. STK, it's your Peutz-Jeghers polyp, colon, stomach cancers, pancreas. Never forget, very, very high risk of pancreatic carcinoma and also breast cancer. If you want an inherited condition, oral melanosis, that also write them, right? Okay. P53 will be seen in almost every cancer. It's the most common gene mutated, right? Okay. Perfect. So this is about colonic tumors. Fine. So this is about tumor suppressor genes in a page, in a single screenshot, right? So let's deep dive into the three things what I said, fine? Because there's a possibility, well, what happened? there's a possibility that these three can come in a short answer individually. Fine. So retinoblastoma. Again, if I want to draw write a short note on retinoblastoma, I need few theoretical points by default. The chromosome number. Anyone? What's the chromosome number of retinoblastoma? Is required. The other extra names, the guardian angel of the genome, or the for this your governor of cell proliferation, that also might be required, right? What is the chromosome location of retinoblastoma? Rishank, almost every leukemia will have PIF3, including CML. When it goes to accelerated phase, will have PIF3. AML in the end stage will have PIF3. And PIF3 will be there. Don't worry about it. You cannot eliminate PIF3 at any point of time from our body. Okay, fine. Retinoblastoma is an governor of cell division or cell proliferation. It's not in first chromosome. It's in 13. Okay, Q14, the chromosome number. Again, the normal function of retinoblastoma is to guard your G1 to S transition. It guards G1 to S transition. That's a normal function of retinoblastoma. Fine. Okay, if you want to draw a cell cycle, saying that a cell from G1, it has to go to S. This guy will stop the transition because it is tumor suppressor gene. It will stop cell division, it will stop cell cycle. That's all right. So it stops the G1 to S transition or G1 to S gate. That's a normal function. So it will have, effectively, it will reduce cell division. Right? So when there is a mutation, the mutation has to be a loss of function mutation, which results in no control. So there will be an G1 to S transition, which will be uncontrolled. It will be an uncontrolled G1 to S transition. This obviously results in uncontrolled cell division, which results in a cancer. Okay. So when you write a short note on any of the tumor suppressor gene, write about the inherited cause also. There's a variant called an congenital retinoblastoma syndrome or in congenital RB syndrome, where the first hit or the first mutation is at birth, congenital. The second hit or the second mutation will be acquired. And this increases the risk of retinoblastoma, can be bilateral. Okay. Vinay, if you can write the E2F silencing pathway, the SG1S phase exactly into the molecules, I'm very happy. At least the basic thing, these are required, fine. Okay. And also you can have increased risk of osteosarcoma. If you remember our last class in the CNS, I must have told something question, trilateral retinoblastoma, where it is bilateral retinoblastoma in the eye plus penioblastomas. This also is possible in a congenital retinoblastoma syndrome, right? That's enough for a short answer. In short, we'll have to talk about that. That's it. Fine. Okay. The gene, one name, normal function, what will happen is mutated, and about congenital retinoblastoma syndrome. The same way we can write for PIF3. PIF3 is 17p13. 17p, that's enough. Okay. So PIF3 is the guardian angel of the genome. The normal function is very simple. Whenever there's a mutation across any part of the genome, PIF3 stops the cell cycle, tries to correct it. If it's corrected, allows the cell cycle to function. If it cannot correct, it will activate backs and back and cause apoptosis. So when PIF3 is lost, when it's mutated, no one to correct any mutation which happens in the body. So it's like an open gate for every mutation. More mutation occurs and causes cancer. One of the worst prognosis amongst every cancer is P53. Leaf-Romney syndrome is congenital. Same first hit at birth, second hit acquired. What all we see in Leaf-Romney syndrome? All this thing. Everything here, what we see will be seen in Leaf-Romney syndrome, right? Okay. I'm just going to go with your APC beta-catenin because APC beta-catenin can be useful in two places. Fine. Which one, Subhojit? Subhojit. Which one you want me to repeat? I'll repeat it for sure. You want PIF3? Okay, let's do it. So PIF3 is the guardian angel of the genome. Okay. It's seen in chromosome 17p. the normal function of p53, when there's any mutation across genome, p53 will be activated, has two outcomes. It will stop cell cycle. Okay, you can stop the cell cycle at any point. Once it's activated, it stops cell cycle. Two options: corrects the mutation, corrects the error, then the cell cycle continues. If it cannot correct the error, it's going to cannot correct the error, or it's a very difficult or a very big error to repair it. If it can't correct the damage, it activates backs and back, which will cause apoptosis. It ultimately kills the cell. That's a normal function. Now let's assume I'm having a mutation. So mutation is going to be by default loss of function or deletion. So there's no one to correct the errors. Then more and more and more errors keeps on happening. Obviously it will increase cell division. Okay, it will increase cell division and it will cause cancers. Fine. Okay, Subhajit. And Lee-Romney syndrome, we saw what all tumors we will see in Lee-Romney syndrome. First is acquired, so first is congenital, second is acquired. Same way, I can see in the sarcoma, leukemias, breast cancers, and your CNS tumors. Fine. Okay. So I just want to add one more guy, APC. APC beta carotin. The reason I want to talk about APC is I can apply this in colonic cancer. If it comes in lung cancer, I can apply it here as well. Fine. Okay, great. Now, colonic cancer is in APC beta carotin is in chromosome 5. The normal function of APC is to bind to beta catenin and destroy it or make it inactivated. That's all. That's a normal function, right? Now, let's say when there is a stimulus for growth. When there's a stimulus for growth or the growth factor, so now what happens is this growth factor stimulus will destroy APC. When the APC is destroyed, this beta catenin guy is free. When the beta catenin is free, that's a proto-oncogene that goes to the nucleus, tells the nucleus, please let's prepare for cell division, and it will increase division. This is what happens when it's mutated, right? So again, when you have an APC loss, the beta catenin is free even without stimulus. That's a problem. If you have a stimulus, obviously I can divide. If there's no stimulus, no division at all, right? That's what happens in APC loss or in beta catenin activation. There are two questions here. APC loss will cause this, or a gain of function mutation of beta catenin will cause the same output, right? That results in uncontrolled or very increased cell division. Okay, you know what to write in congenital. You have to write, if it's in a short note, write about FAP. You have to write about attenuated FAP. You have to write about the variations of Turcot as well as Gardner. Okay, if it's in a colonic adenocarcinoma long node also, write all of them. Right, it's the same pathogenesis, different outcomes because all of them are. And do remember one more thing you can write. All these cancer syndromes are dominant or recessive? What do you think? The cancer syndromes, dominant or recessive? By default, almost every cancer syndrome what you see are dominant inheritance only, and you can fairly say it's an autosomal dominant inheritance because it's very, very unlikely to be an X-linked dominant inheritance. Fine. You can write that also, right? Lee-Romney is autosomal dominant, your neurofibrinoid is autosomal dominant, one hippolyndo is autosomal dominant, FAP is also autosomal dominant only. Fine. Okay. So we know a little bit about tumor suppressor genes. Altered cellular metabolism, right? So altered cellular metabolism, you have to write about two things. If it comes in a short note, please don't stop with Warburg's effect alone. There's something more called as oncometabolism. Write both, because both of them are due to altered cellular metabolism, right? So if it's an altered cellular metabolism, I have two pathways which is there in Robbins. Both should be there. Obviously, I have to write about Warburg's effect and also about oncometabolism. or an oncometabolite, right? A mutation in your IDH or an SDH, which alters the Krebs cycle, produce a new metabolite which causes cancer. That's oncometabolite, right? So what is Warburg's? So Warburg's effect, we read in detail about Warburg's effect, and also we can have a practical application of Warburg's effect with respect to Burkitt's lymphoma, right? So what Warburg said is, Warburg said that tumor cells consume only glucose, aerobic glycolysis or anaerobic glycolysis, and consumes glucose by only by aerobic glycolysis. The electron transport chain does not happen with respect to Warburg's effect because of the mitochondria selectively destroyed in tumor cells by a process called as mitophagy. It will stop at aerobic glycolysis, right? This is what Warburg's effect is by definition, right? The reason why this happens is simple. So the end of the glycolysis, the product lactic acid, this will be converted into your nitrogen bases for DNA and RNA, because that is very, very, very important for me for a growing or a fast dividing cell. Okay, this is what primarily Warburg's effect is. Fine. Okay. Bhumi, therapeutic strategies in sense you want the, I don't think there's any therapeutic strategy for now for a tumor suppression of P53. But if I can produce something which can give, see, P53 ideally I cannot target it. None of the tumor suppression I can target it because loss of function. We can target only gain of function. I have more, I produce monoclonal antibody and block it. When there's less, I cannot add on to it. The only possibility is I can do a gene therapy to introduce new P53. And that's very, very difficult. Fine. Okay. Okay, so this is what Warburg's effect is. You must have had a query. You will definitely have this query when you go and start reading. Why lactic acid when I say aerobic glycolysis? That's why I said the problem here is not becoming lactic because of anaerobic. It is aerobic only. But there's no mitochondria because of mitophagy. For me to complete the last step, pyruvate, I need the mitochondria. That's not happening. That's why it goes to lactic acid, and the lactic acid gives me DNA and RNA. Fine. Perfect. Okay. So now this is what it is. And the regulator of Warburg's effect is your MYC proto-oncogene. Okay, that's a regulator of Warburg's effect, right? So what happens when there's an MYC gene mutation? Every proto-oncogene mutation will be a gain of function mutation only. As a gain of function mutation, any MYC gain of function mutation, write this term, this word has to be there, gives stemness to a cell. It makes any cell a stem cell because it will activate Warburg's effect, gives an uncontrolled growth potential, right? So we have two mix, C mix seen in your Burkitt's. Long answer, if you have more time, write bit about Burkitt's, talk about Ki67, 100%, right? And N mix seen in your neuroblastomas of children. Okay, so these are two mix, both of them are uncontrolled cell division, grows very rapidly, both neuroblastoma as well as Burkitt's lymphoma. Fine. So that's in short about Warburg's effect. Okay, therapeutic, if you want about talk about therapeutic strategies here, not exactly scientific, but the intermittent fasting kind of works in this way, right? Not exactly scientific, so let's not go into it. This is what Warburg's effect entails, right? So now let's talk about the second part of my altered cellular metabolism, which is oncometabolism. Okay, so oncometabolism is nothing but because of a mutation in an enzyme, I'm having an intermediate that is activating or causing genetic alteration. That's called an oncometabolism, right? So here, a mutation in an enzyme of the metabolic pathway is producing an intermediate which causes genetic alteration and which causes the tumor genesis, which results in the genetic change. That's what oncometabolism primarily means. A simple example is IDH. Can anyone tell me one tumor where IDH is involved? That's the last class what we saw about. Most of the CNS tumors, glioblastoma and everything, IDH is involved, right? Perfect. So IDH mutation is an example for it. Okay. So now IDH is isocitrate dehydrogenase, right? Normally it produces alpha ketoglutarate to 3-hydroxybutyrate, right? I think I'm right. That's the normal mechanism. But when I have a mutated IDH, so that will cause an alpha ketoglutarate due to mutated IDH produces 2-hydroxyglutarate. This is called as an oncometabolite. This is an abnormal metabolite. We call it an oncometabolite. And this oncometabolite, what it does is, this will cause epigenetic changes. That results in cancer formation. Okay. That's what oncometabolism primarily says. It's a normal thing, changing to something else and creating an epigenetic change resulting in a cancer. Great, right? So examples, which tumor I will see, at least one you can definitely know that. Just write glioma, oligodendroglioma, glioblastoma, both of them have it. Glioma is a decent one. If you can write both oligodendroglioma and glioblastoma, great, right? And also write leukemias. Leukemias also have IDH, few subtypes which you might or not learned, right? One more example is SDH. Any tumor comes to your mind? SDH, two tumors, just paragangliomas. Pheochromocytoma, paraganglioma, we have lots of SDH, right? RCC also, just RCC, paragangliomas. Okay, great. No space, so I'm just writing RCC small, fine. Okay, so these are three tumors where I can have SDH mutation, fine. Oncometabolite composed 2. If the question is on, tell me about altered cellular metabolism with respect to neoplasia, write both. If the question is specifically asking Warburg, write only Warburg. That time, expand Burkitt's a little bit more. If it's 2, this is enough. Few words for Warburg, few words for oncometabolite, more than enough for you to write in for a 5-mark question, fine? Okay. Next hallmark is invasion and metastasis. If a question on 5-mark comes on invasion and metastasis, at the end of it, write at least in the form of a table, lymphatic hematogenous seeding of body cavity, one word about it. It will complete the cycle. If the question is talking about metastasis and its roots, pathways, then start with metastasis and maybe in few words write the steps of metastasis also, right? Because in Robbins, mets is discussed in 2 places. One, the mechanism, the other, the way it spreads. Both of them are interdependent. Based on the question, you decide what to write first, fine? So invasion and metastasis, both these are very, very, very classical hallmarks of cancer. Obviously, when it's invaded or metastasized, I will say it's malignant by default, right? So first thing I have tried is exceptions. Tumors which don't spread, example, or very, very, very rarely spreads. You know the example, BCC. Must, that is required. Basal cell carcinoma is a tumor which very, very rarely spreads, is required, right? You need not write what is a benign tumor which spreads. This is more than enough for me, right? Then for me, the question talks about steps of metastasis. Okay, steps of metastasis. Write the step in the left side. Rishank, that's what we discussed long back, no? Neoangiogenesis. New blood supply, more glucose, consumes more energy. Fine? Okay. So if there's a question on steps of metastasis, left-hand side, write the theory part. Right-hand side, write the diagram. If you see in Robbins, there'll be a big blood vessel. And they'll write one by one. Write that. It's more descriptive. Need not be beautiful. Need to be descriptive. That's all. So draw a skin here. Draw a tumor here, which is invaded. You can write here saying it is invasion. Invasion is in a squamous cell carcinoma is the breach of the basement membrane. That's all. Is invaded, right? So now the first step of metastasis for me is loss of E cadherin. Is a passenger mutation or a driver mutation? Here it is passenger. That makes a single cell or a couple of cells come outside. That's the first step. It detaches from the main thing, right? So here you can write, because of the mutation, they detach from the main tumor mass. It's going to go outside, that's all, right? Perfect. You can write that also as passenger mutation if required, right? Second step, when it comes, what's the next step? It will start slowly moving into your extracellular matrix, right? They have to destroy the extracellular matrix, right? So you have destruction of extracellular matrix or the stroma, right? That's the second one, right? Okay, perfect. So for that, I need to draw a collagen. So it's going to destroy the collagen. It definitely can be destroying the collagen. How do they destroy collagen? Write the know-how here. By, like when I said, by producing or by increasing the production of matrix metalloproteases, like collagenase and your elastase, fine? It's locally aggressive tumor, Ipshita. So if I can diagnose a BCC and operate it, yeah, it's very, very, very decent. I must have told in lecture also, right? The Hugh Jackman, Wolverine, had BCC on his face 3-4 times or even more than that. Still acted on Deadpool was Wolverine. Didn't have a problem, right? They're subtle tumors, but has to be operated by default. Fine. Okay, that's the second step. So once it has destroyed it, it has to move. That's third step is epithelial mesenchymal transition. Write don't write EMT, write epithelial mesenchymal transition, right? So here what happens is the epithelium becomes a mesenchymal cell or a spindle-shaped cell. The reason is by activating two genes, twist and snail. Easy way to remember. Epithelium is round, twists itself to become spindle shaped. Twist moves like a snail. Those are genes which is getting activated. Once it's activated, it can move. The fourth one, once it slowly moves, it has to reach a blood vessel. You can draw a blood vessel. It has to reach a blood vessel or a lymphatics. Here we have drawn blood vessel, right? So it has to reach blood vessel and it has to enter the vessel or lymphatics. For this entry also same guy, matrix proteinase collagenases will destroy the base membrane, will come inside, right? Slowly once it came inside, what happens here is inside the vessel I have tumor emboli formation. So it's not just the tumor will be surrounded by WBCs. Tumor will be surrounded by platelets. It's like an immune defense mechanism for me. It is surrounded by platelets, it's surrounded by WBC, and it roams across. So once it keeps on roaming like this, the fifth step is chemokine mediated exit. Based on the chemokine, it's going to go outside of the blood vessel or lymphatics. One chemokine, at least write this, don't forget, right? CD44, hyaluronic acid, helps or promotes your lymphatic metastasis. So whenever a tumor cell goes outside, it helps in the lymphatic metastasis. CXCR4 also great. If you know, you can write it, fine. Obviously, right? It will create subclones. But you tell me, Rishank, subclone is required for spread or subclone is required for the tumor to form? It's monoclonality only. Even the subclone, the initial mutation will always be there. See what you're trying, I'll just give a real life analogy. I'm an Indian, you are an Indian. If I trace back long back, we all came from the same things. But at some point of time, multiple things kind of diverged. So if I take my genetic data, your genetic data, we both will be Indians only at some point of time. Then we came back, right? That is clonality for me. The clonality is a stamp which always will be there in every cell. Subclones are new mutations, that's all, fine? Okay. So CD44 is something which is required. CXCR4 or CCR7 are for breast cancer. It goes to lymph node, right? Once it goes outside, that's a sixth step where in the metastatic site, you will have the MET reversal of mesenchymal to epithelial transition, and it will deposit and it will grow. Here it will always be multiple well-defined mass in the periphery and might have central necrosis or central umbilication. So these are very classical finding for all the metastatic deposit, right? I have narrowed it down in one page, but it's very easy for you to draw neatly, write legibly in 2 pages, more than enough. 6 points if it's there for the steps of metastasis, no one is going to ever question you again. All these are classical points. You need not write essays. If I'm looking at EMT as a heading, epithelial to mesenchymal transition, requirement is to move across the stroma. How it happens? With the help of twist and snail. Moves, enters, that's all. Loss of E cadherin. A passenger mutation creates a subclone which is ready to spread from the main tumor. Loss of E cadherin will detach them, go outside. Fine. Just 2-3 points for everything. That's more than enough. Don't write an essay. You can write bullet points. That's more than enough. No one is asking you to form an entire sentence. It's not required. If you know the content, that's more than enough for me. More than enough for the examiner as well, right? So that's about invasion and metastasis steps. Fine. Okay. We'll go with one more molecular hallmark. That's your mechanism of immune invasion in cancer, right? If I am an examiner, I would ask about this because immunotherapy is something which is kind of making the entire oncological management look a little bit positive, that hopefully that immunotherapy will be the next big thing which can help us in killing cancers. Not sure, but it's at least perceived as a next big thing, right? So obviously we will need to talk about evasion of immune response or evasion of immune surveillance, right? So the first and the foremost thing, why should my immune cells kill cancer cells? Okay, or which all part will trigger the immune response, right? One, I have a mutated self protein. A mutated self protein is not a normal protein, will trigger the T cell, right? It's a mutated P53, it's a mutated E cadherin, it'll definitely trigger it, right? Second, overexpression of a normal protein. You know that for a fact that whenever any protein is overtly expressed, my immunity by default will kill it. That's a trigger, right? By default, it will kill it, right? Third, we'll have oncogenic viruses. It's a virus. Virus has to be recognized foreign by my body and should be killed, right? So these are the reasons why my immune cells will be destroyed by cancer. And who will destroy them? Primarily T cells. Because all these are intracellular problem, primary T cells, you can write CD8, CD4, and obviously to some extent NK cells. NK cells also does a role, and NK cells I don't care much about it. It's an innate immune response. They're not very strong, right? So since I have altered self protein, overexpression of self protein, and oncogenic protein coming inside, my body has to identify tumor as foreign and kill it. But why it's not happening, right? In spite of this, cancers evade. Cancers evade your immunological surveillance. How do they evade? One by one. The first is CD8, a simple mechanism of loss of MHC1. If MHC1 is lost, a CD8 cell cannot recognize tumor cells because that's a signaling receptor for me, right? It has to be a problem, right? I cannot have overexpression of any protein in my body. If you remember this apoptosis, one of the reasons why your cystic fibrosis cells die is abnormal protein accumulation. Abnormal protein will cause endoplasmic reticulum stress. It will trigger an automatic cascade of cell death. Why is prion a problem for me? It's an abnormal protein, right? Anything in excess will be considered abnormal, will be automatically destroyed. Fine. Okay, let's come back to this. Second is your CD4. So we know about CD8. Let's go about CD4 again. Fine. So CD4 You need not explain about energy much, because here I'm not looking at you whether you're correlating the topic or not. But CD4, if I want these two terms here. Increased expression of CTLA4 and increased expression of PD1 will result in suppression of, this word is required, co-stimulatory molecules. Suppression of co-stimulatory molecules will automatically make my CD4 cells recognize tumor cells or the cancer cells as self-antigen. If my co-stimulatory cells are gone, I obviously will think it as a self-antigen. That's my problem. That's how they escape your immune response of CD4. Fine. B6, B7 cells will be suppressed by CTLA4 and PD1. Right. Next. Okay. Third, the neutrophils or my innate immune cells. Right. Cancer cells increase the production of TGF beta, interleukin 10. These are considered primarily as an anti-inflammatory cytokines, because TGF beta is one of the most important thing which causes desmoplastic response, right? But they're anti-inflammatory, so obviously this will reduce all the WBCs like neutrophil, basophil, eosinophil to come in near to it, right? That also is going to help me escape my immune response. One thing which is still confident and still killing the tumor is NK cells. Like I said in the start, I don't mind because they might kill few. They are innate immune response, not that strong and effective, right? So this is how we escape it, right? It should always end with, what's the advantage here? So the immunotherapy. So immunotherapy, like chemotherapy, is a branch of cancer treatment. So immunotherapy is, we are just activating the patient's or the host immune cells to kill cancers. How do you do it? Very simple. We have antibodies to CTLA4. I don't think now we'll have a problem in naming the antibodies. When we started, it was very difficult, right? Now also it's difficult only. Ipilimumab, right? Or the drugs. Who starts? That's all. We have antibodies to PD1. You have your pembrolizumab, nivolumabs, right? So these are ipilimumab, nivolumab, pembrolizumab. You might know more drugs than me, right? All these are your immunotherapy agents. So this will make sure the CD4 now will recognize tumor cells as foreign, and they will destroy, and they have a very beautiful outcome, right? But when you give this drug, side effect, adverse drug reactions, you will have autoimmune rashes. I cannot stop it. Has to happen. It'll happen for sure. Autoimmune rashes. This also has increased the risk of your ANCA-mediated vasculitis. Please write this. Don't forget this. This is actually having a very pretty bad outcome in patients with who's taking nivolumab and pembrolizumab. The Wegener's, Shock-Strauss syndrome, microscopic polyangiitis, they are an increasing incidence, right? Okay, that's about immunological surveillance. Why should they kill? Who kills? And how do I escape? Why should they kill? 1 mark. Who kills? Maybe half a mark. How do I escape? Maybe 2-3 marks. And then how do I use it as an application, right? That's enough for us, fine. In an exam, I require structure. I don't want you to write in paragraphs. If you want to get a good mark, do something for yourself before writing an exam. Mentally for 10-20 seconds, think what you're going to write. Don't just go and write like in 12th standard. I don't want essays. I really don't want pages. If you can write properly, concisely, more than enough, very, very happy about it. Fine. Let's go to paraneoplastic syndrome. Paraneoplastic again is a very potential topic for a short note, very easy and very limited. Viva can definitely come. Again, definition. Signs and symptoms that cannot be explained by anatomical or the hormones indigenous or physiological. If I cannot explain a symptom with anatomy or the physiology of the tumor, I call it paraneoplastic. I'm not going to use it for diagnosis. It's an adjuvant to diagnosis. It's only this doesn't make it diagnostic. I need help, that's all. And also to track recurrence or prognosticate. Hypercalcemia is seen in case of squamous cell carcinoma. I remove the squamous cell carcinoma of the lung. Hypercalcemia will have to come to normal. If it increases, paraneoplastic or a recurrence happening, right? That's why prognosis and also helps in the diagnosis of the patient, right? Few classical paraneoplastic syndrome, 4-5 with examples should be more than enough. If you know more, write more. Excess is not always a problem. Less is always a problem. But at least these are some simple things which I want you to remember and write, fine? Cushing syndrome, the most common endocrinopathy in paraneoplastic syndrome. Overall, the most common paraneoplastic syndrome is hypercalcemia. Where do you see Cushing's? Small cell carcinoma of lung. Okay, right? And also seen in pancreatic tumors. In both these conditions, what's there? You'll have ACTH-like substance. The reason. So the tumors release ACTH-like substance, so you'll have Cushing syndrome, right? Ishita, specify the lung cancer. Because lung cancer is a blanket term. I need to know it's small cell carcinoma of the lung, right? Hypercalcemia, squamous cells here of the lung. Please don't use the term SCC. We had a problem during discussion also. What is SCC? Small cell or squamous cell, right? Please write squamous cell and small cell. Fine. Okay. Squamous cell carcinoma of the lung. Breast cancers can have. Okay. Even your myelomas can have, right? Adult T cell leukemia lymphomas can have. ATLL. A viva question. What's the microscopic diagnostic cell in ATLL, adult T cell leukemia lymphoma? The reason is it has PTH related peptide. It's related peptide that causes the more, right? Okay. Then you have polycythemia vera. It's seen in clear cell RCC or something related to VHL syndrome or your cerebellar hemangioblastomas is due to increased erythropoietin. The answer for ATL is clover leaf shaped RBCs. Sorry, clover leaf shaped cells, right? Looks like a clover leaf due to HTLV1 virus, right? Acanthos nigricans. By default, the first thing I'm going to think of is an insulin resistance, right? If not, GI malignancy, uterine cancers, leiomyosarcomas to be specific, right? The reason for it, it's immunologic and increase in the EGFR. Okay, epidermal growth factor receptor is being increased, so it becomes very thick and black. That's all, fine. Trossius phenomenon is migrating superficial thrombophlebitis. Just write any mucin secreting adenocarcinoma. And the reason is mucin can activate factor 10 directly. If it activates factor 10, obviously it will more likely to possibly to produce clots. That's all, fine. Red cell aplasia and myasthenia gravis. Seen in thymoma, again an immunological reaction. Okay. One thing which I didn't write, which I want you to write also, is SAADH. SAADH produces ADH hormone by small cell carcinoma of the lung, which causes syndrome of inappropriate ADH secretion, right? 4-5 examples, solid examples. It's not must that you have to write everything, but write solid examples and also mention the use and the definition should be good enough for a 5-mark question, fine? But don't miss this part, what causes it. And maybe if you want for the prognosis part, you can write, give an example. I have a tumor, I do a surgery, it will come back to baseline. So once there is a recurrence, it will come back again, right? You can give that as an example, fine? Great. Okay, I bet on two things, paraneoplastic syndrome and tumor markers. Any one of this should be there in a paper. As a 5-mark, or if university has 2 marks, something should be there, right? oncogenic viruses. Carcinogenesis, more than chemo, radio, oncogenic viruses or microbial carcinogenesis, is very important because it's much more organized and has lots of things to remember and write as well. It's not, say, if I talk about chemical carcinogenesis, write some random name, causes mutation, that's all. Radiation, direct, UV rays causes mutation. But here I have the organism, I have the gene or pathogenesis, and whatever cancer it causes, right? HTLV1 virus increases in a gene called as TAX gene. TAX gene increases cell division. These are all viral proteins or bacterial proteins and genes which causes adult T cell leukemia lymphoma. Okay, very aggressive type. HPV, if it's a long answer, write about the subtype. 6 and 11, 16 and 18. If it's a short answer, write only about the carcinoma, leave about the genital warts, right? So HPV 16 and 18, it has increase in your, it integrates into the DNA, into the human DNA, and it produces your E6 and E7 proteins. This reduces retinoblastoma. This reduces P50, sorry, the reverse. This reduces P53. This reduces retinoblastomas. Fine. Okay. Cervical cancer. I would write anogenital cancers. Cervical, any anogenital. Penile, vulval, anal canal, any anogenital cancer is there. Laryngeal cancers, oropharyngeal cancers are also HPV related. Okay. Fine. EBV is Epstein-Barr virus. Epstein-Barr virus, I have protein called as LMP1 protein. Is a viral protein. Sorry, the virus protein which increases your B cell proliferation. So that's why most of the B cell lymphomas cause it. I'm just writing B cell lymphomas. I'm not specifying which tumors, but if you want, you can specify Hodgkin's, non-Hodgkin's, Burkitt's. Even in Hodgkin's, quite a few of them will have EBV positive, quite a few of them will not have EBV positive, right? I'm just writing B cell lymphoma. EBV is also related in few more tumors. Since the infectious mononucleus causes kissing disease, nasopharyngeal carcinomas. Sure, Rishank. Okay, I'll reply today. Back-to-back classes, so only. Fine. And also, it's slowly getting implicated in gastric carcinomas. Okay, so I have to remember at least these basic three things. Fine. Okay. HHV8, there's an cyclin D1's analog. The protein is like cyclin D1. Okay. So obviously HHV8, what does it cause? Kaposi sarcomas, right? Anything else? We have a tumor called as an primary effusion lymphoma. All of them will need one requirement of immunocompromised state, right? And we have one more disease called as Castleman's disease. All these are HHV8 or human Kaposiform virus related, right? This is just due to chronic inflammation. It does not have a classical genetics of the virus causing it. Chronic inflammation, that's all. Obviously, it is hepatocellular carcinoma. H. pylori have your CAG-A and vacuolating islands of gene VAC-A, which increases your pro-inflammatory cytokines. So it increases your risk of gastric carcinoma and also your maltoma. If you want, write the indirect link of reducing your risk of esophageal carcinoma, but I wouldn't mention it. I wouldn't write it. Gastric carcinoma, maltoma is more than enough, right? Schistosomiasis, chronic inflammation. Which tumor? This also is chronic inflammation. That's a reason. It causes bladder carcinomas. And your clonocytogenesis causes the bile cholangiocarcinomas. Fistula hepatica, cholangiocytosis, all of them go and rest in the biliary tract, irritates the biliary tract, and results in tumors of the biliary tract, which are termed as cholangiocarcinomas. Right? Wait. Okay. I'm 100% sure if you want this to extend and write, you will be able to write it. It's an organism, right? So let's say I'm asking you as a 10-mark question, HPV. Any organism has a route of infection. You can write about that. You can write about the strains. We can write about the types of tumor. We can write in depth about the pathogenesis. EBV, oral cavity, you know the route of infection, right? HHV8, talk about your HIV for sure. Hepatitis, you know the route of infection. H. pylori, you know the route of infection. Schistosomes, you know the route of infection, right? You can elaborate it easily. Shrinking is a problem. You won't have never have a problem of elaborating it. I'm sure you'll do it, right? Okay. Last but not least is tumor markers. Possibly, this can also, like I said, PNS tumor markers will be there at least in one of the places, be it a Viva or an MCQ or a 2-mark or a 5-mark question in the paper. Fine. Tumor markers, these are blood tests, okay, which again aid in diagnosis or is useful, same like a paraneoplastic syndrome, to follow up the patient, right? Or is useful to assess recurrence. Okay. The only difference between this and paraneoplastic syndrome is symptom and sign. This is a blood test. Recently you told calcitonin. That's a blood test. That will not have a symptom or a sign, right? So paraneoplastic syndrome versus tumor markers, the only difference is there's a blood test or a urine test. It's a lab test. That is a symptom and a sign, right? This is again not diagnostic of a cancer. I do have few other non-neoplastic conditions also will elevate it, right? Few simple things. Human chorionic gonadotrophin. You can write molar pregnancy also. And obviously you can write choriocarcinomas. Okay. Calcitonin. Medullary CA thyroid. Next one. Where do you see them? These are all Viva points. Fastest finger first. Where do you see catecholamines? Catecholamines and its metabolites, which means catecholamines and metanephrines. That's a metabolite. You see them in neuroblastoma. Can I see them in pheochromocytomas? Yes, no, maybe. What do you guys think? It's also a tumor coming from neurological tissue, right? I can see them in pheochromocytomas also. Okay. Let's say ectopic hormones. This is where your ACTH like peptide, PTHRP, some of them can be assayed. The paraneoplastic syndrome, some of them also I can assay it by default, right? Great. Alpha fetoprotein, I see them in yolk sac tumor, or if I want to write in a bigger term, I can write non-seminomatous germ cell tumor, but yolk sac tumor to be specific, and definitely hepatocellular carcinoma. AFP of more than 1000, the first diagnosis liver, right? That's the first diagnosis, right? Carcinoembryonic antigen, remember it's like your Trossio phenomenon. Carcinoembryonic antigen is a mucin's product. It's a product from the mucin. So same, any mucin secreting carcinoma can be colon, can be lung, can be stomach, can be pancreas, anything. It has to be only one thing. It should be a mucin secreting tumor. Can even be ovary. You can write whatever comes to your mind, but it has to be mucin secreting. Then obviously CA will be elevated. Fine. Okay. Immunoglobulins. Where is immunoglobulins? Simple, myelomas. The light chain ratio and the slim criteria, right? And prostate specific antigen membrane antigen seen in prostatic carcinoma. Okay. CAs. CA, you know, CA 125 is something which we read recently. That has to be memorized. Ovarian carcinoma. And your Instagram influencer school bro made the rest of it easy. 9 looks like this. It looks like pancreas. Okay. 3 looks like a breast parenchyma seen in breast cancer. Okay. Fine. Stupid thing. Helps to remember, that's all. Let's not go and fight whether it's right or wrong. It's okay, it helps me, that's it. That's more than enough for us, fine. Okay, so that brings us to an end of neoplasia. Neoplasia is a big subject, but neoplasia is something which can be easily compiled because it's short. Whatever we read in neoplasia and the general pathology is now understandable, and you have applied it in systemic pathology, so it will definitely be easier. Any question in general pathology, please think for some time, see how you can structure, see how you can find a relation and apply it. Fine. Okay. Thank you, Bengal Medical. Any doubts? Do let me know. Mucin and CA relationship. See, Rishank, have you heard about something called glycoproteins? CA is something of that. Fine. Okay. Any other doubts? My next class on Sunday. I think I'll be going with RBC disorder. I might be a little bit late on Sunday. I might not be on 6:30. Not sure. I'll update you guys. Fine. Thank you guys. See you on Sunday. So I think once we complete RBC, that's on Sunday. We have done almost everything required. We have done RBC and we'll do RBC and coagulation on Sunday. WBC is done. Neoplasia is done. Quite a few systemic pathology: CVS, lung, GIT, liver, kidney, female genital tract, breast is done. Right? So we'll have to just look at a few more things of immunology genetics. I'm sure that's an overlap between microbiology and us. You'll be able to do it. And very simple general pathology topics. Fine. Breastfeeding and lactation. See, lactation, there's a concept called lactational amenorrhea. When a woman is lactating for almost, let's assume, 1.5 to 2 years, the cycle of estrogen and progesterone will not be there because it will be prolactin predominant, right? So 2 years, no proliferation. Imagine 2 years, you don't open the book, knowledge will be wiped out. 2 years, no estrogen, breast parenchyma will slowly lose the whatever had division, it will go off. That's why it helps. Agranulocytosis is a very severe granulocytopenia. That's all. Leukopenia is some agranulocytosis is less than 500. Very severe is agranulocytosis. A is absent. Rishank, secondary osteosarcoma is nothing but you have a tumor on an existing some other bone problem, like a radiation, like a Paget's. That's secondary. Secondary means happening on something else. Primary is happening de novo. Fine. Okay, Rishank. I won't, Srimati. I think those are very small. If you want anything, do let me know on that. Fine. Yeah, it's already damaged one, no? Same. If it's an inflammatory condition, radiation, you know how it can cause. Pages is a very highly proliferating place. Lots of blood supply, lots of cell division happening, osteoblastic phase, too many growth happening. So there's a possibility I can have a mutation. Fine. Nulliparity does not reduce the risk. Nulliparity causes, it increases the risk of breast cancer. Okay. Fine.